Welcome. This is Maria Hussey with the Juvenile Diabetes Research Foundation. I am the development coordinator. Welcome to our show, What is Type 1 Diabetes? And I'd like to introduce my guests. Carl, would you begin?
Sure. Thank you, Maria. My name is Carl Marks. I'm the Executive Director of JDRF for short, here at the Florida Suncoast chapter in Southwest Florida.
And?
My name is Dr. Anastasia Albanese O'Neill. I am a professor in the College of Nursing at the University of Florida, and I also work in the Diabetes Institute at the University of Florida.
Thank you very much for both being here. And Jessica?
Yes, my name is Jessica Ferguson, and I am a clinical research coordinator also at UF with our diabetes research program.
Thank you all for being here. This is very kind of you. Anastasia, tell us exactly what is diabetes? What is type 1 diabetes?
That is a great question, Maria, and there is so much confusion out there. We hear about diabetes every day on the news. I think that you can't get away from hearing about diabetes, and there are different types of diabetes. The two that most people will have a family member has are type 2 diabetes and type 1 diabetes. This program is about type 1, but I want to tell you a little bit about type 2. Type 2 diabetes, but diabetes in general, is having too much glucose or sugar in your blood, and that can lead to complications. You hear about complications like blindness or kidney disease and other problems that people experience. But type 2 diabetes is related, it's been on the rise, and as the proportion of Americans who are overweight and don't exercise increases, we've seen an increase in type 2 diabetes. In people with type 2 diabetes, their body produces a hormone called insulin. And what insulin does is it unlocks the cells and lets that sugar in our blood into the cells so that we have energy. So people with type 2 diabetes can actually reverse the course of the disease and prevent it through exercise and through changes in diet. They may also have to take medications. Today we're talking about type 1 diabetes, which is very different, even though they have similar names. So type 1 diabetes occurs, we think, is an autoimmune disease. We know that people who get type 1 diabetes have a genetic risk, meaning we can identify people who are at risk through a simple blood test. But most people who are at risk don't get diabetes, type 1. However, we know there's an environmental trigger, and we don't know what that is. We're doing research on that Jessica will probably talk about later, that causes these people to lose the ability to produce insulin. And if that insulin isn't produced in very short order, within a few weeks, there can actually be very severe complications. You need insulin to survive. And in countries where people can't get access to insulin, the prognosis with type 1 diabetes is about 6 to 8 weeks. So we must replace insulin with type 1 diabetes.
And this is growing, I understand.
It is. Even though the genetics haven't really changed, we're seeing an increase in the incidence of type 1 diabetes. In fact, in countries like Finland, the incidence is as high as 1 in 125 people. And we believe that type 1 diabetes is doubling every generation here in the United States. So we need to find out what that environmental trigger is.
So education is very important.
It is. It is.
Carl, JDRF is very involved with research. Can you tell us a little bit about that?
Yeah, sure. Well, our organization was started as the Juvenile Diabetes Research Foundation. We now call ourselves JDRF. It was first called that because typically individuals with type 1 diabetes happen to be juveniles. I, for example, was diagnosed when I was 12 years old, 40 years ago. And over time, we discovered that this type of diabetes can affect anyone at any age, from small infants to people who are adults. And so it affects people of all ages. But our organization was developed in 1970 with one sole purpose in mind, and that was to fund research in order to find a cure for what we now call type 1 diabetes, T1D for short. And so it was started by two moms They were the parents of children with type 1 diabetes, T1D, who felt that not enough public funding of research was going on. So they got together, they did a fundraiser. I think they raised $1 million in year one, and they were thinking, wow, this is the genesis of something that could really make a profound difference in the lives of people. So since that time, our organization has grown. We have funded research throughout the world. We still are. We have funded over $1.8 billion of research, of type 1 diabetes research.
terrific.
Absolutely. $120 million just right here in Florida since the year 2000. And we are currently managing a portfolio of research in the $500+ million range. And that research is across any number of therapeutics, but mainly around the areas of curing the disease, very importantly, preventing the disease, and then how can we more effectively manage the disease so that people with T1D can live longer, more productive lives with quality of life without the long-term complications getting in the way. So that's what our organization does, and we have a chapter here.
Thank you. Thank you very much. Yes, and that is the Florida Suncoast chapter. Jessica, can you tell us a little bit? He mentioned that prevention is one of our areas of focus. And can you tell us a little bit about what's happening at the University of Florida?
Yes, so we have a lot of focus on prevention. So typically what we are looking at is, one, identifying people that are at a greater risk, and we tend to look more at family members for that. Also finding ways to identify people at greater risk. So is it the presence of autoantibodies? Is it their ability to have a normal glucose tolerance after an oral glucose tolerance test, or other factors that we're looking into. And then once we do identify people at risk, is there something that we can do to try to prevent that autoimmune attack? So we have, we're very active in the TrialNet program at UF. So we have the natural history study that is looking at family members, trying to find those at risk. And then if we do find people at risk through that study, we can filter them in to one of hopefully 3 active prevention studies that we have going on right now.
I find myself referring people to TrialNet quite a bit. Could you elaborate exactly what that TrialNet test is all about?
Well, TrialNet is actually the network. So we have now 7 active recruiting studies in TrialNet. We have the natural history, actually my math may be wrong at the moment, 3 prevention studies, a long-term follow-up, and then we just launched a new onset study as well for people newly diagnosed. So TrialNet is actually the network. It's an international network.
So you mentioned newly diagnosed. What does that mean?
It is typically for people that have been diagnosed within the last 100 days.
Is that critical? Is that important?
Yes.
That is important.
Yes, that is important. So they would need to start either, they would need to be randomized to treatment, so usually either placebo or active drug within 100 days of diagnosis. And that is in an effort to help any remaining beta cells that they have, and those are the cells that do make insulin, help them be able to continue functioning, and like Carl said, hopefully decrease risk for complications down the road.
You know, it's funny, Maria, you mentioned we're talking about prevention, and I wonder if some of the listeners might be interested in what some of those symptoms might be.
Oh, that's a very
when
good
somebody is
idea.
newly
That's a very
diagnosed
good
with
idea.
diabetes. Yeah, so with type 1, as we said, that onset is very sudden. That was probably the case
Pretty
when
much.
you were diagnosed. What people will notice is they may have a child who was potty trained and can sleep through the night, a 7-year-old, and all of a sudden that child is wetting the bed again.
Okay.
That's a sign that the kidneys are trying to get rid of that extra sugar, and so that child is going to the bathroom frequently. They may be on a road trip somewhere and may have to stop a number of times to go to the restroom, much more often than they normally might. Or a small child, a 2 or 3-year-old who has gotten potty trained, all of a sudden is having a lot of accidents. These are things. Increased thirst. People with new onset type 1 diabetes are very thirsty. In addition, these folks are typically fairly thin, but they might start losing weight. So unexplained weight loss, again with those other symptoms of increased thirst, increased urination, and the fourth thing we look at is increased hunger. So remember, insulin is the key. It unlocks the cells, it lets that blood sugar into the cells, and these folks can't use that energy. So even though they're eating, their body, they're turning to fat to have energy because they can't use the sugar that's in their blood for energy. And so if you see these symptoms, you really need to call your primary care physician. And as Carl mentioned, 50% of the time this happens in adults. We see a lot of adults in diabetes misdiagnosed with type 2 diabetes that we talked about because they're adults. That disease used to be called adult onset diabetes, and type 1 was called juvenile diabetes. We had to rename those because kids now get diagnosed with type 2 and a lot of adults get diagnosed with type 1. So we really urge people, if you see these symptoms, if you see a family member exhibiting these symptoms, definitely talk to your primary care physician, be very clear about the symptoms you're seeing, and then if the diagnosis does occur, get in touch about research, because some with new onset studies, there is a very short window.
And in the U.S., there's 15,000 adults, 15,000 children diagnosed with T1D in the United States every year.
Every year during
Every
this
year.
show, someone will be diagnosed with type 1
Absolutely.
diabetes. That's
Now, we're talking about prevention. Now, during this research period of time since 1970, what kind of treatment are we looking at now for type 1? What areas of treatment or to live better with type 1?
Absolutely. So I know that Jessica talked a little bit about prevention. Some of the management, and she'll probably say a few more things about that, but in terms of the management, diabetes is a very challenging and labor-intensive thing to manage, especially
is.
type 1.
Yes, it
You
is.
are a human pancreas, whoever is managing it, whether it's the person themselves or the parent. And that means checking blood glucose up to 8 to 10 times a day. That's pricking your finger, and that involves replacing that insulin. Now, for a long time, we did that via injection. That
Now,
was-
you mentioned the pancreas. Why the pancreas?
well, the pancreas is what produces insulin.
Oh,
The
okay.
pancreas produces insulin, and so you are. It does a lot of other things too. It's a very incredible organ, the human
Several
body.
hormones,
Yes,
right?
several hormones.
Yeah.
But what they're working on now, I actually have a daughter with type 1 diabetes, and when she was 2 years old, she went on something called the insulin pump. And JDRF was behind a lot of research around the insulin pump because instead of drawing up insulin into a syringe, which can be frightening, and delivering that insulin, she was able to use a device that said it was inserted just below the skin, and she could push buttons to deliver insulin.
At 2.
At 2. And well, we helped, certainly. But what's great is those devices have evolved and now have calculators and can actually help patients. But where it's gone next is to something we're calling the artificial pancreas.
That's exciting. I heard a little bit.
It is amazing. You are right. And what that technology does is, for the heart, we have something called a pacemaker. You don't tell your heart when you have a pacemaker to beat, 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 beat all the time. What the artificial pancreas does similarly is it manages that blood glucose hands-free. So the person with diabetes, now it's experimental right now, you cannot run out and get one of these, but we actually had some clinical trials at diabetes camp and where people were out walking around in public. And what that did is it measured glucose levels, communicated through an algorithm on a smartphone with the pump, and delivered insulin using that algorithm to prevent highs and lows. There was also another hormone involved in one of the studies called glucagon, and that tells the liver to put sugar in the system so people don't go too low. Because when you go too low with type 1 diabetes, there can be complications in that direction as well. So this research is really exciting because it would make management much less complicated and keep people safer.
Carl, can you tell us a little bit about encapsulation?
Sure. And
That's another area of research JDRF
absolutely,
has gone
very
into.
exciting research that is going on right now. And one more thing about the artificial pancreas is, we currently have really good technology. I'm on an insulin pump. I'm on a continuous glucose monitor, which several years ago was unheard of.
Right.
And so my continuous glucose monitor is communicating with my insulin pump constantly. And so I have one visual of where I am and where I'm headed, either high or low or whatever. But the artificial pancreas would take it a step further where I don't have to make these human calculations. The mathematics will do it for us.
I agree. And you
And-
know, not to interrupt, but I get really excited when I hear about this research or people talking about it. We do have one step in the artificial pancreas is actually out there and people are using it. And what that is Carl talked about his pump, his continuous glucose monitor, communicating with his pump. There's a system out there right now that will turn off insulin at night if people go too low.
I'm on that system.
There you go. So
It's helped me out a lot.
Yeah.
I can tell you because, and you know, people often ask, wait, okay, so you have diabetes, that means high blood sugar. Why is it sometimes people with type 1 diabetes crash and they go too low? How is that even possible? It seems counterintuitive.
Agreed.
Well, that's because we're trying to manually do as best we can what we can do to deliver just the right amount of insulin based on what we eat and exercise and stress and all these other things. But sometimes we can't get it right. And so our blood sugars plummet too low. And
Agreed.
very low blood sugar hypoglycemia is very dangerous. So
Absolutely.
my insulin pump, in fact, in the first week that I got this particular pump, it suspended one night because I didn't hear my glucose monitor telling me that I was falling.
Right.
And so it suspended for 2 hours. And after that 2-hour period, it kicked back on. And by that time, my blood sugar had crept back up.
See, and that is extraordinary. And I think, you know, you think of maybe some parents and their child's going to go away, move out. They're going to go work in a job somewhere far away, or they're going to go to college for the first time. And those parents are thinking, who is going to look after my child when they're sleeping alone in an apartment or in a dorm room? And you have this technology
Yes.
that is protective, and you've actually experienced it
Yeah,
yourself.
it works, and it's exciting stuff, yeah.
So that is really thrilling. And I think I just want to emphasize what you said about the challenges to managing type 1 diabetes. You know, if you exercise actively during the day, you might have to completely change the amount of insulin you take that night that you're getting because you're at risk for going low. And this technology, we hope, will take some of that burden of management out of the process. And you can tell us more.
Anything we can do to lighten the load of people living with the disease is what our organization's committed to, and all the research that's going on is all about.
Exactly.
Encapsulation, you asked about that. So that's exciting stuff. So you heard mentioned earlier that the beta cells are the cells in our pancreas. And there's, relative to other cells in the body, there's few of them. There's not a bunch of them. But anyway, those are the cells that produce the insulin. They help regulate your blood sugars. With type 1 diabetes, those cells stop working. Or even if they work a little bit, the immune system keeps destroying it. So we started funding research about 5 years ago to figure out how can we develop insulin-producing beta cells, but then protect them from being destroyed by the immune system. So we funded a company in California called ViaCyte, and they have received public funding as well. And they have developed insulin-producing beta cells that they encapsulate or surround with a compound around these cells such that once implanted in the human body, the insulin is able to flow through the compound easily, oxygen can get to those cells, etc., but the immune system cannot penetrate that compound, and therefore it's protected. I think we have a researcher at University of Florida who once called it the shark cage. Picture a shark cage, a human being is in that cage. Let's say the human being is the beta cells, and water is flowing through the cage, everything's working fine, but that shark, the immune system that's going awry, cannot get into the cage. We're really excited that that company has brought this to clinical trials. It has been implanted in 3 people, and the goal is ultimately to have this implanted through an outpatient procedure, not a radical surgery, and you're insulin-free for 18 to 24 months.
I was wondering if you're going to say
Yeah,
that.
and then you just go
I think
in and
that's
have
fantastic.
the insulin, have those cells replenished. So we're really excited about that. That's what encapsulation is all about. University of Miami, DRI, we fund them as well.
Yep.
They're working on similar technology and similar therapies in the encapsulation area. So, and that's the thing about JDRF. We're sort of like the mutual fund of research. We invest in research throughout the world. We have a very diversified portfolio, even sometimes in the same area, to ensure that this group is working on this approach, this group is working on that approach. We make sure that there's collaboration there, and eventually either one or a combination thereof will deliver the therapy we're looking for, including the cure, by the way. So,
And speaking of the cure, what would the cure look like?
the cure, the cure is defined differently by different people. Being a purist, I would say a cure would mean that I have no device, I have nothing implanted. We figured out how to get your body to start producing insulin-producing beta cells again, and the immune system, whatever went awry with the immune system has been turned off and it's not destroying the cells again, and your body returns to the normal production of insulin and the normal regulation of blood sugar levels. That would be the ultimate pure cure. So it would require a combination of two things: producing the beta cells and turning off the immune system. That combined would be a cure. That, in the most purest sense, is what the cure is. But the cure means other things to other people. An artificial pancreas that makes your life so much easier, yeah, you're tethered to a device, but some people would look at that as a form of the cure. Encapsulation, if I could go 18 to 24 months without having to take insulin or check my blood sugars, that's as close to a cure as you can get. So different definitions of the cure, for sure.
And now, this has been going on since 1970, this research. So this is not something that's happened overnight. So this requires a great deal of funding. How does that happen?
Yeah, as someone once said, with enough time, energy, resources, and money, we can solve anything. So yeah, money is obviously an important resource to make this research happen. We all know, we read the numbers, the statistics. To deliver a drug or a therapy to the marketplace can take upwards of $1 billion or more. That's a lot of money. Because clinical trials are very expensive. They start off slow. Trial phase 1 might be 6 to 10 or 12 patients. Then they move into phase 2, and that brings in more patients. Then they move into phase 3, and you're talking about perhaps there are thousands and thousands of patients. All that takes a long period of time, and all that, by the way, is regulated by the FDA. They ensure that all of this is done safely and effectively. And so it takes a long period of time, and it takes a lot of money. That's why our organization was founded in the very first place 40 somewhat years ago, and that's why we exist today, to help through programs and fundraising raise the money that's needed for the research. We have given $60 million to the University of Florida through the fundraising we do. We've given money to University of Miami, University of South Florida, and then we advocate for public funding of research also. Special Diabetes Program,
That's right.
$150 million a year, helps supplement what our private donors and individuals and supporters give us.
That's very exciting. That's very exciting. And especially here locally, we are going to have 2 activities taking place to help raise funds for research for type 1 diabetes. The first one is the JDRF Polo Cup, and that's going to take place on February 15th. And you can go to the floridasuncoast.org website for tickets. It's going to be held at the Sarasota Polo Grounds, and we are very, very excited about it. It's a fun event to join us with. The other thing is that we are going to have the JDRF One Walk, and the One Walk will take place on April 18th in Lakewood Ranch on Main Street. It's a 3-mile walk, and we are in the process of forming teams right now. So if you'd like to contact me, you can contact me at mhussey@jdrf.org, or my phone number is 941-685-6875. So were there any final things that you wanted to say before we ended our show today?
I didn't respond to one of your questions, and I apologize. I was caught up in semantics. So the test that I believe you were referring to that we screen for, it's usually the screening part of we have branded it the Pathway to Prevention study, but it's the TrialNet Natural History Study, are autoantibodies. And these are markers that can be found in the blood up to 10 years before someone is diagnosed with the disease. So we can do a simple blood test and we will send it off to the labs for processing, and we can look for 3 to 5 autoantibodies specific to type 1 diabetes.
And if someone's interested in that program, how could they get in touch with you?
They can go to there's a TrialNet, there's a main TrialNet website. They can go to, we have a TrialNet at UF website. There is multiple centers actually in this area as well, USF in Tampa, All Children's in St. Petersburg. There's over 200 sites in the States
So
where
there are
we can
quite a
do the
few.
testing. Yes.
There are quite a few. Well, I'd like to thank you very, very much. This was a tremendous opportunity to learn about type 1 diabetes, something to clarify that I think that helps our public understand a little bit more about the disease and what we're doing to try and prevent it. So I'd like to thank you, our audience, our viewing audience today. I hope you have learned about type 1 diabetes and will join us at our special events. Thank you very much and have a great day.